Good morning, ladies and gentlemen. Today's topic is the last topic in the series of acquired pigmented disorders. So today I'm going to discuss all those conditions in which there is non-melanin pigmentation. So the first is the endogenous non-melanin pigmentation. A variety of normal constituents of body may give rise to alteration in skin color if present in excess or in abnormal forms or sites. These substances are formed as a result of metabolic defects and that can produce the pigmentary changes. Special stains of histological specimens or techniques, such as spectroscopy, may help to identify the nature of exogenous and other non-melanin pigments in the skin. Cutaneous hemosiderosis. Hemosiderin, as you all know, is a brown iron binding pigment which is found predominantly within macrocytes. The deposition of hemosiderin is commonly a result of local destruction of RBCs after RBC extravasation in the dermis. The hemosiderin stimulates melanogenesis, and much of the dyspigmentation that is associated with hemosiderosis may in fact be due to melanin rather than hemosiderin itself. So the accumulation of hemosiderin in the dermis and consequent hypermelanosis result in brown or coppery discoloration of the skin. Coppery is slight grayish discoloration of the skin. Cutaneous hemosiderosis may arise through a number of different mechanisms, of which the most important are the following few. Number one, trauma, particularly repeated ecchymosis from minor trauma to the lower limb. This can be seen in occupational hazards, as an occupational hazard or in sports. Then hypostatic hemosiderosis is associated with chronic lower limb venous hypertension. Capillaritis or Schomburg's disease also produce pigmentation, which is called as pigmented purpuric dermatosis. Then congenital hemolytic anemias, including sickle cell anemia, may also produce hemosiderin deposition. Hemochromatosis, and this may be due to deposition of skin as the result of repeated episodes of purpura from any cause, for example, clothing or drug-induced dermatitis. Clinical variants, the hypostatic hemosiderosis. In chronic venous hypertension, there is leakage of blood from the small blood vessels into the tissue. This extravasated RBCs are broken down by tissue macrophages and release iron, which is incorporated into hemosiderin, and that remains predominantly intracellular within the macrocytes. This pigmentation or the iron produce more or less uniform deep brown or coppery color. All the biopsy samples from the pigmented skin will show a higher melanin content at the dermoepidermal, at the basal layer, than those of unpigmented skin. Interestingly, a study of 46 patients with various types of leg ulcers, it was shown that hemosiderin could be detected in skin biopsies from all patients, but that urinary hemosiderin was absent in all patients. So it was just cutaneous hemosiderosis. This is how this pigmentation in chronic venous hypertension would look like. Capillaritis or pigmented purpuric dermatosis, hemosiderosis without clinical evidence of hypermelanosis is seen in Schomburg's capillaritis. Reddish brown plaques with cyan paper point beyond their margin are present on the leg and thighs and sometimes on the arms, more or less symmetrically present in middle-aged and obese male and female. Congenital hemolytic anemias like sickle cell anemia produce conspicuous pigmentation of lower leg in the 3rd decade or earlier. Management. The treatment is that of underlying cause, and after treating that cause, this condition can be arrested. Then second kind of non-melanin pigmentation we come across is jaundice and bronze baby syndrome. Jaundice is the yellow discoloration of skin, eyes, and mucous membrane due to deposition of bile pigments. Clinically, it is often first noticed in the sclera because bilirubin has an affinity for elastic tissue. Bronzing is the effect of added melanin pigmentation is often seen in jaundice of long duration. The outcome depends on the management of underlying disease. So bronze baby syndrome, there is bronze discoloration of the skin, mucous membrane, and urine after phototherapy in children with clinically severe jaundice. The nature and origin of pigment is uncertain. The discoloration is caused by abnormal accumulation of photoisomers of bilirubin, which is photodestroyed or accumulation of biliverdin. These changes are reversible unless there is some chronic underlying liver disease. Well, in most of the cases, this bronze discoloration vanishes in a couple of months. So you can see that the skin was normal at birth, but once phototherapy was started, the skin has turned to grayish brown in color, and later on, it is after 5 months, the skin is returning back to its normal color. Differential diagnoses include carotenemia and gray baby syndrome, which is due to high dose of chloramphenicol. Management: the bronze baby syndrome has no treatment, as pigmentation is reversible after discontinuation of phototherapy. The neonatal jaundice is routinely treated with 460 to 490 nanometer visible light. That is the phototherapy. Carotenoderma. Carotenoderma. The carotenoderma is benign yellowish coloration of skin due to elevated blood carotene levels. This may be primary due to diet or secondary due to, for example, hepatic disease. The primary carotenoderma is seen most obviously in food fetishists who consume large amount of oranges or carrots. The iatrogenic carotenoderma occurs in patients on oral supplements of beta-carotene as a photoprotective agent in erythropoietic protoporphyria. The carotenoderma typically occurs when beta-carotene concentration exceeds 200 microgram per deciliter, with daily ingestion exceeding 30 milligram of beta-carotenes. In secondary hypercarotenemias, that is seen in hyperlipidemia, diabetes, nephritis, and hypothyroidism, it may also occur if conversion of carotene to vitamin A is impaired by an inborn metabolic error or by some hepatic disease. So this is the cause of secondary carotenemias. Pathology: the carotene is a lipochrome that contributes yellow component to the normal color of the skin. In presence of excessive blood carotene, the yellow component is increased. So clinically, it will give a yellow color that is most conspicuous where the horny layer is thick, that is on palm and soles. Scleras are not discolored as we see in jaundice. So that it is treated by a diet which is low in carotene, which will lead to resolution of the signs. So you can see this excessive yellow discoloration of palmar skin in carotenodermas. Ochronosis. Ochronosis is a two types, the endogenous and exogenous. And endogenous ochronosis is a term which is used when in combination with L-captonuria. It is a pigmentary change that occurs in connective tissue in patients with L-captonuria. Exogenous ochronosis is discoloration of skin after the topical use of strong hydroquinones. And the individuals are mainly those with dark skin tone and may also be caused by use of phenol or resorcinol. The incidence and the prevalence. Endogenous ochronosis is present in about 75% of patients with alkaptonuria. Exogenous ochronosis, the exact incidence is unknown. Alkaptonuria is a congenital condition with equal male to female ratio. Alkaptonuria is seen in all races, while exogenous ochronosis is mainly reported from South Africa. Predisposing factors. Exogenous ochronosis is also seen in Asia, because here there is a lot of trend of getting white, and people have a dark skin. So predisposing factors, the exogenous ochronosis is associated by use of skin lightening cosmetics, mostly reported with heavily pigmented skin. So in addition to hydroquinone, phenol and resorcinol containing depigmenting agents are also implicated. Pathology. Histopathology of both ochronosis is characterized by comma or banana-shaped ochronotic collagen bundles. So pigment is basically on collagen bundles. Histopathological differentiation between two forms is not possible. In alkaptonuria, a deficiency of homogenistic acid oxidase causes accumulation of homogenistic acid throughout the body. While in exogenous ochronosis, it is caused by inhibition of homogenistic oxidase and accumulation of homogenistic acid, which polymerize to form ochre, that is a brown yellow pigment in papillodermis. Genetics. Alkaptonuria is an autosomal recessive condition. Environmental factors that are important for exogenous ochronosis is excessive sun exposure and higher concentration of hydroquinone, that is more than 3% for prolonged period of time, that is more than 6 months. Clinical features. Endogenous ochronosis, there is darkening of ear cartilage, of the sclera and conjunctiva. Less often axillary skin is pigmented. Brown mottled pigmentation of face, sometimes in a butterfly distribution of neck and trunk. Rarely pigment on the palmar and plantar skin is also seen. So you can see this pigmentation on the face, and is also seen in the sclera and the cartilage, and even on the bones. The exogenous ochronosis, there is gray-brown or blue-black macules with slight thickening of the skin in the areas which comes in contact with hydroquinone, normally face, neck, back, and extensor surfaces of limb. No hyperpigmentation of cartilage, sclera, or conjunctiva is seen. So you can see this exogenous ochronosis. Not only there is increased pigmentation, but the underlying skin is also thickened. And on histopathology, you can see these banana-shaped pigmented collagen bundles in the dermis. The differential diagnosis of ochronosis is the several endocrinopathies like Addison's disease, Cushing syndrome, or hyperthyroidism. Certain metabolic conditions like PCT and hemochromatosis. Then poikiloderma of SAVAD, post-inflammatory hyperpigmentation, and toxin and drug-induced hyperpigmentation or discoloration. For example, amiodarone and doxycyclines. Investigation. Alkaptonuria may be identified by urine organic acid analysis, whereas exogenous ochronosis is identified by patient history and maybe skin biopsy. Management. The first-line treatment for alkaptonuria, there is no definitive treatment. Nitisinone, ascorbic acid, nitisinone or ascorbic acid 1 gram per day in divided doses, and protein restriction to 1.3 gram per kg per day may be beneficial. For exogenous ochronosis, discontinuation of hydroquinone and strict sun avoidance. Then for treatment of discoloration, TCA and cryotherapy. Some improvement is by retinoid acids. Low potency corticosteroid in combination with photoprotection is also useful. Second line treatment is, although results are not uniform, the superficial dermabrasion using carbon dioxide laser, glycolic acid peeling, or Q-switch laser improves this skin discoloration. Exogenous pigmentations. A wide variety of chemicals, either occupational or medicinal, can produce discoloration of the skin. Of importance are the silver, gold, mercury, and bismuth, which are cumulatively deposited in the dermis and can produce permanent disfiguring pigmentation. A number of drugs can discolor the skin, and they include the antimalarials, phenothiazines, clofazimine, and minocycline. We have discussed about these drugs in the previous lecture. Of less importance is the transient staining of the skin, which is produced by picric acid, dinitrophenol, and chemical dyes. Metals. The first is ergyria. This develops as a result of systemic absorption or external contact with silver. Source of silver is deposited in the skin as a medication or from industrial exposure. There are cases of generalized ergyria occur following ingestion of colloidal silver, which is available in many folk medicines, which are given for various conditions that include diabetes, AIDS, cancer, and chronic infections. Cases have followed use of silver salt for irrigation of nasal, oral, and urethral mucous membrane, or excessive use of oral smoking remedy containing silver acetate. Food supplements may also contain colloidal silver. A cumulative dose of 4 to 5 grams is required to produce the clinical signs. Light microscopy. Silver granules are seen in the dermis that are most numerous at the basal lamina of the eccrine sweat glands and in the dermal elastic fibers. Silver granules are readily visible with dark field illumination, and diagnosis of ergyria established by skin biopsy. Clinically, the pigment is of slate gray color and becomes apparent in few months or years. This hyperpigmentation is most apparent in sun-exposed areas like forehead, nose, and hands. In some patients, entire skin becomes slate blue colored. Sclera, nail, and mucous membrane may additionally become hyperpigmented. So pigmentation is usually permanent, and treatment with depigmenting agents is not effective. Sun protection can limit further pigmentary change. You can see this normal individual turned into the ergyria with slate gray pigmentation throughout the face and the body. Then arsenic. Prolonged ingestion of inorganic arsenic results in diffuse pigmentation, most intense on the trunk. There is diffuse, dark brown spots, or diffuse, darkening of the skin on limbs and trunk. This hyperpigmentation is characterized by macular areas of depigmentation within areas of hyperpigmentation producing a distinctive raindrop appearance. Many cases also show arsenical keratosis, expunctate keratoderma on palm and soles. You can see this typically raindrop appearance, the depigmented areas in hyperpigmented background. And in addition to these raindrop signs, there can be punctate keratodermas on the plantar surfaces and the palmar surfaces. Bismuth. Administration of bismuth at regular intervals over a period of years are often practiced, yet generalized pigmentation is rare. If present, the pigmentation is diffuse gray resembling that of ergyria and involves sclera and oral mucosa and sometimes vaginal mucous membrane. A distinctive blue-black line occurs on the gingival margin. This is deposition of bismuth that reacts with hydrogen sulfides that are formed by bacteria in the mouth. Chrysiasis or chrysoderma. This is the term which is used for the permanent pigmentation of the skin due to parenteral administration of gold salts. These salts are no longer used, but when it was used, the excessive administration led to deposition in connective tissue. And the diagnosis is confirmed histologically with dark field illumination and on electron microscopy. The granules of gold are larger and more irregular than those of silver. The chrysiasis appear to be inevitable in patients receiving more than 150 milligram per kg of gold and develop after a few months or after a longer latent period. The pigment is blue-gray or give a purplish hue and limited to light exposed skin and on the sclera. Oral mucous membrane is not affected and the discoloration is permanent. Mercury. Repeated application of mercury-containing compounds can produce localized hyperpigmentation of the treated areas. This pigment is observed in upper dermis, around the capillaries, and associated with collagen and elastic fibers. The systemic administration of mercury results in gingival hyperpigmentation, and a case report of intended homicidal subcutaneous injection of metallic mercury results in widespread skin lesions that appeared after 40 days and began to clear in 6 months. Tattoos. The accidental tattoos. Pigmented particles may be accidentally introduced as a contaminants of a wound or may at high velocity penetrate previously intact skin, producing disfiguring tattoos. Such irregularly scattered pigmentation is quite commonly seen after road accident and blast injuries. Some particles may eventually be extruded, but disfigurement is often permanent. These tattoos often respond well to Q-stitch, anti-yag, or pico laser. Small lesions may also be excised. Then, Collier's stripes. These are very distinctive occupational marks in coal miners. The bluish-gray linear or angular stripes develop at sites of abrasions, which is common. Commonest site is the forehead, bridge of nose, wrist, and elbows. Histologically, particles of coal dust up to 100 microgram in diameter are seen at all levels in the dermis. They tend to be grouped around the blood vessels. Therapeutic agents, iron salts. The use of solutions of ferric sulfate and ferric chloride in treatment of dermatitis has been followed by reddish-brown tattoos. The pigment may disappear after a few months or persist indefinitely. The occupational contact with iron salt produce red-brown punctate perifollicular pigmentation of the forearms. Crystal violet, gentian violet. This has exceptionally given rise to tattoo when applied to a wound or a face. Then history and prevalence of the decorative tattoos. From ancient time, the practice of tattoo has developed, and tattoos are traditionally being used to accentuate beauty or as a permanent adornment in most sociological and cultural context. Tattoo with words or names as a symbol of dedication or devotion have always been popular. Tattoos may also be a manifestation of deliberate self-harm. Another contemporary trend is to use of temporary black henna tattoos. This is what we come across commonly. These are not true tattoos, but represents application of black dye to produce tattoo-like appearance that lasts for a few days. Unfortunately, a high concentration of well-known contact sensitizers, paraphenyline diamine, is usually present in these tattoos that results in contact allergy and sometimes permanent pigmentation and even scarring. The techniques and materials. The professional tattooists use electric needle to introduce particles of pigment into the dermis, and the pigments commonly employed include the blue-black, which is carbon, red is cinnabar or vegetable dyes, light blue is cobalt, green is chromic oxide, yellow is cadmium, and brown is orc or iron oxides. So these are different color tattoos, but the most common are the blue-black tattoos. Complication. Infection, allergy to tattoo pigment, and cognirization of other disorders, particularly sarcoidosis to tattoo, represent the most common complications. A sarcoidal granuloma in tattoo may be a presenting manifestation of generalized sarcoidosis. Foreign body granuloma or sarcoid type is reported in ochre tattoos, that is iron-containing tattoos, which have high silica content. Tattoos may also be complicated by keloid formation. Removal of tattoos. Although most people who choose to have tattoos are satisfied with them, there are many who wish to have them removed for various reasons. Small tattoos may be amenable to removal by simple surgical technique. However, recently the advent of pico laser is now most widely used for tattoo removal, and their effect on blue back tattoos is very good, but it is not much effective in colored tattoos. So this brings to the end of this talk, and I thank you all for a patient listening and hope to see you soon with another edition of my lectures. Goodbye and have a good day.